This is the New Hampshire Insurance Department's webinar to review the network adequacy template and requirements in anticipation of form filings for plan year 2027. So my name is Michelle Heaton. I'm the Director of Life and Health here at the New Hampshire Insurance Department. And I have with me today Morgan Harris, our Director of Healthcare Analytics, and Quincy Gunn, our Administrator of Life and Health Compliance. Some of the things we're going to go over today is a brief overview of New Hampshire's approach to evaluating network adequacy, along with an overview of our template, the tool we use in our resource file that we put out there to assist carriers. We're also going to review how to interpret some of the results from the tool and some tips on how to properly respond if there are any concerns noted. So just to give a brief overview, New Hampshire has been regulating network adequacy for some time. Our rules are in INS 2701, and in recent years, we have been undertaking some efforts to really revamp our network adequacy and make sure that it complies with the federal requirements so that it continues to be as stringent as those federal requirements. CMS has been deferring, and they continue to defer to New Hampshire to enforce those network adequacy requirements. As we undertook some of that work, we updated our tool. And the most recent iteration of that tool we first implemented last year in May of 2025 for plan year 26. From plan year 25 or 26 to plan year 27, there have been no changes to the rules, but we just wanted to take this opportunity to walk through the tool and the template and how everything works again, just so that everyone is up to speed in advance of next year's filings coming in. Also of note, we are in the process of updating our INS 2701 rules with respect to network adequacy. Those rules will be entering rulemaking very soon. However, they should not have any impact on our review for plan year 2027. And we do plan on having another webinar as soon as those rules go into rulemaking to go over what changes in the rules and to provide some feedback as to some of the changes we're making. So New Hampshire's approach has a little bit different compared to CMS and other jurisdictions. So in New Hampshire, we take a service-based approach, whereas CMS and many other jurisdictions take a provider-based approach. And so our service-based approach, we are looking at the services being provided to covered people in our state, as opposed to looking at what providers are making up a network. In order to do this service-based review, we rely on our all-payer claims database to cross-reference those providers that are on the network adequacy filing to ensure that they are, in fact, actually rendering care in New Hampshire. That's a little bit different than the CMS and other jurisdictions where they're really just relying on the network filing. Another key difference in New Hampshire compared to other jurisdictions is that because we're doing a service-based approach, we're looking at all claims, and we are not necessarily narrowing that down to just physician providers, whereas the CMS network adequacy framework is really focusing on physicians only and may not include other providers such as APRNs who are able to practice independently in New Hampshire. So one of the other ways our approach differs a little bit is that we also use a framework of reference zip codes. So for each of the counties listed there, you can see that there are specific reference zip codes we use. So we determine our time and distance based off of those reference zip codes. Most counties have 2 reference zip codes, but Merrimack has 1 and Grafton has 3. And that's because of the geography of our state. And that's why we like our approach in New Hampshire, because we're really taking into account where services are actually located, where people actually live, and just some of the geographic quirks of way, counties are drawn up. We also use county designations of rural, middle, and urban, and that's based on population and spread. We then break out the services into common, core, and specialized. And I believe I said that wrong. Core, common, and specialized. Although we do have different naming conventions for these classifications, our county designations and our service designations do align with the federal network adequacy, federal network adequacy framework. So if you're looking at specific services for a certain type of provider, those time and distance standards are analogous to what they would be at the federal level as well. Next slide. So these are our time and distance standards for those common, core, and specialized based on the rural, middle, and urban designations. The maximum travel distance and travel times are based on the service type and the county. The time and distance are measured from the provider's zip code to each of the reference zip codes, and that's a key thing to understand. Next slide. I'm going to kick it over to Quincy.
So we have a few frequently asked questions that are sprinkled throughout our presentation. The first one that we get pretty commonly is, can in-network providers located outside of New Hampshire be included on the template and used to meet network adequacy requirements in New Hampshire? And the answer to that is yes, absolutely. We definitely encourage you to include any providers you think might meet time and distance standards for residents of New Hampshire. We are a small state, and a lot of towns are actually closer to bigger towns in Maine or Vermont or Massachusetts. So it's very possible that those providers could help you to meet network adequacy requirements. You should definitely include them on your template when you submit it to us. Another question that we get pretty often is, what if our plan is not offered in all New Hampshire counties? And it's just important that when you file your network adequacy template in SURF, that you just clearly indicate any counties that you're not marketing your plan. So as long as you include that and it's clear to us, it'll make it easier for us to get objections back to you that makes sense for the counties that you're offering your plan in.
Thanks, Quincy. I'm going to take it over from here. I'm just going to do a really... Yeah, thanks, Quincy. I'm going to do a high-level dive into what you guys can expect from the tool output, as well as some of the resource files that we have on our website for you all to use. If you guys are in need of the network adequacy template, nothing on that has changed for the past couple years now. That's still on our website, along with the resource file, which I'm going to get into a little more in depth in the next couple of slides here. But those are found on the Life and Health page of our website. It's also going to be where we're going to be posting this presentation, this recording, and a couple other resources for you all as well, all under that network adequacy section. So please take a look at that on our website and use it to your advantage. It's really helpful. So as both Michelle and Quincy talked about earlier, we use our APCD data to run our network adequacy tool, which is extremely unique, and I'm only know of us that do it. A lot of other jurisdictions defer to the CMS tool, which Michelle touched upon being more geo-access based than what is actually being billed for. So we run through the tool, and then we give you guys the results to kind of show where any deficiencies are so you guys are aware. Next slide, please, Quincy. I'm going to walk you all through what a medical and a dental result would look like, so you all know kind of what all the variables are, how to interpret them. And it's really important to know that we see red and when we think it's scary and we think it's automatically a failure. It's really just for us to notify any deficiencies to you all and to just have a conversation on maybe what you guys are doing to fill those gaps, or if there are gaps that can't be filled, just making us aware of those. It's not saying that you're going to automatically fail. Getting the red back doesn't mean that you have a network that's not acceptable. It just means we need to do a little more discussion back and forth to see if there's any places to increase your network, or if not, then any sort of exception request to follow. So this should look familiar to you all. This was the output that was given last year. Nothing has changed. Nothing's changed in the way that the rule is, the way that the tool works, as Michelle said earlier, and nothing will change in the results. It'll look like this this year as well. So I'm going to walk you guys through kind of how to interpret this real time here. So I'm going to start with just row 2. You have an alcohol drug substitute detox service. That's in Carroll County. The reference zip code is 03813. And your column G here, your frequency, that's going to tell you the number of times that the alcohol drug subacute detox service was billed within the last calendar year in our all-payer claims database by a NPI that was listed on your network adequacy sheet. Now, this isn't necessarily 23 unique providers. This could be someone that has billed 23 times themselves in Carroll County, or maybe a mix of providers, or maybe it is all 23 unique providers. We don't check to make sure that it's 5 unique providers you need to pass. It's based on the service and how many times it was billed. So your G column is going to tell you how many times, like I said, you have a provider that had billed for that service in Carroll County. And then the score column right next to it is how many times you actually met the time and distance standards that Michelle outlined in the previous slides for you all. So of the 23 claims for alcohol, drug, subacute detox in Carroll County, you had 1 time that met the time and distance standard. This is below the threshold of 5 that we have set, and I'm going to talk a little bit more about that threshold in a little bit. But that's below that threshold, which is why you have that -1 there, just stating that, hey, this service was below that 5 claim billing threshold that we set, and we might need to have a conversation with the carrier to see if there are any sort of gaps, or maybe there's just no alcohol, drug, subacute detox providers in Carroll County. Maybe there's just the one. Maybe that's why we see that a lot. So this is really just to not only help us understand what's going on in your networks, but to also, like I said, kind of walk us through with you to see where there's gaps. We know from last year that a lot of the alcohol, drug, substance use, behavioral health services were the majority of the ones to fail. We expected that. We know, especially in some of the more rural areas, that there's just not enough providers providing services for these, and you might not have enough to meet that 5 threshold. That is okay. That's why we have the exception request process, and that's why we're always open to walk through your results with you. So that's how you would interpret this for a medical example. Quincy, if you want to move on to the next slide, I'll do a dental real quick. Same thing, same layout, just different F services, just different services that we're testing for, of course, because this is dental. So same thing, you have your row 2 here, you have Carroll County, you have that reference zip code that we're looking at for dental diagnostic services. They had a pretty good billing frequency of 229 claims within the previous year APCD data, but again, only 1 met the time and distance standard that was outlined. So that's how you would interpret a failure. If you look actually all the way at the bottom at row 11 here, you can see an example of a pretty strong passing service here. You have your dental general services for Belknap County. 164 times were billed, 161 met the time and distance standard. So only three of those claims was either someone driving from outside the county to go to that dentist for some reason, or something along the lines of that. So that's really good. That's a good passing rate. That's a lot of the claims are meeting the time and distance standards. And as Michelle had alluded to earlier, we're allowed to use non-physician providers to meet these thresholds, which is really nice. So that only helps you all. You can have your APRNs, your PAs, as long as they have their own NPI and they've been billing independently of a doctor under their NPI, they can meet in that frequency, can meet the time and threshold in that score column. Next slide, please, Quincy. One frequently asked question that we got a bunch last year is what happens if a carrier has a small market share in New Hampshire and they're concerned about using claims data that doesn't accurately represent the service availability in their network. Our tool uses the whole all-payer claims database for New Hampshire, so it's every insurer that we get that submits to the APCD is in there, and we use the whole billing claims history for that. So as long as if you have a provider with an NPI on that network adequacy template that you all fill out and submit to us, as long as you have that provider on your list, and if he's billed within the claims database, maybe it wasn't even by you, maybe it was by a different insurer, that doctor would still meet the network adequacy requirements, at least to be able to then see if they're meeting the time and distance standard. Doesn't matter if they are being submitted into the claims database exactly by you. I'm sure another insurer has them and they're submitting claims for them, and if they're in their network, it should grab all of those as well. So don't be alarmed. for my smaller folks that have some of the smaller markets, it's taking everyone in consideration pretty equally. Next slide, please, Quincy. One thing we wanted to touch was the 5 billing threshold, kind of where it came from, why we changed it, so on and so forth. So since the network adequacy tool started many years ago, I think it was about 2010, we started doing this. The threshold was very low. You only needed one claim in one of the reference zip codes to pass. And it really wasn't giving the department any useful information as to what's going on in networks because everyone was passing. To us, there was no gaps, even though we know from industry and we know from legislatures that things like alcohol and behavioral health, primary care, women's health, we know there's gaps, but we just weren't being able to see those because our threshold was so low. We did a sensitivity analysis, the data analytics unit did, and we determined that a passing score of 5 gave the department more information as what's going on in your networks without catastrophically failing everyone. Our goal isn't to fail you guys. We want everyone to pass in your networks. You all passed last year. We would assume you all would with this year, since it's still the same 5 billings. It's really just to help us understand where the gaps are and to work with you all to see if there's anything that we can do to get some of those gaps decreased. So that was kind of why we decided to go forward with updating the threshold. We also decided that you needed to pass in both of the reference zip codes. That was really because of some of your larger counties like Grafton County. You have 3 reference zip codes, but you only needed to be passing in one of them originally. Well, that leaves people all the way on the other side of the county potentially having to drive way farther than they need to, maybe across Grafton County to get those services. And we weren't really looking at what was happening in their reference zip code. So that's why we, even though it was different than what was in the rule right now, we decided to expand that just to make sure that we are looking at all the reference zip codes and seeing what's going on throughout the whole county and not just in one little secular area. Next slide, please, Quincy. I talked briefly about the NHID resource file. This is a great Excel file for you all to go ahead and download off of our website. We update it semi-annually, and it's to reflect using the prior year's claims data, who was billing for the about 1,200 CPT codes that we use in our tool. This is not an exhaustive list, and further research can be done to see if there's any providers that aren't on that list that you guys contract with. This is just all of the providers that are in our claims database. We know we don't capture all of them. We might be missing some maybe that only contract with self-insured plans, things like that we might not see in our APCD data. So please don't take this as the end-all be-all, but it's a great resource for you guys to start and to look and see who you might be missing in an area that you might be a little less sufficient on than others. Next slide, please, Quincy. So this is what the resource file looks like. Like I said, it is a great tool. You can see not only by NPI, but by name and by city, where you have your providers that are billing for a specific CPT code under that specific service. So you can see down at the bottom, we have it broken down nicely by county, so you don't have to worry about filtering through there. So let's say, for example, you had a deficiency come back with an alcohol drug treatment outpatient service in Belknap County here, and maybe you don't have Sarah Bernier on your network. This would be a good place for you to start and go through and see who might be billing that you don't either have in your network yet, or maybe it wasn't on your provider list, stuff like that. You can see in column L the zip code of the provider. Column M is the reference zip code, so you can see the time and distance traveled there as well, and see that these people would all meet the time and distance standard for each of the services that they are listed under. Next slide, please, Quincy. One thing that we've also done recently here in the past couple years is we added the whole list of CPT codes into that resource file as well, so that you all can go in and see for each service that we're testing for, which billing codes are we using to determine whom is billing for those services. This is a good tool for you all to go in and use your own claims experience. If you are being deficient in the alcohol drug acute detox service, maybe you can go into your system, look up those H codes, see who you might have billing for those and kind of what's going on there. So we added this, I'd say a couple years ago, and I've heard good feedback that has been helpful to take it back on the insurer's end and be able to use to help rectify any sort of failures.
So another frequently asked question that we get is if you have a different MPI listed for a provider than what is listed for them in the resource file, how should you correct this? We see issues like this with MPI all the time. There's usually some discrepancies. It's just really important that you're submitting your templates using the MPI that providers are actually using for billing to get the best result from the tool. So the MPIs referenced by the tool are those that you submit to us on your network adequacy template and those that are being submitted to on the claim when providers are billing. So you just want to make sure that you are truly using the MPI that providers are billing under when you submit that on your network adequacy template. So once you get your results back from us, we'll write an objection through SURF, just listing out the deficiencies that were noted. Again, we don't want to call them failures. It's more, we want to know what you're doing to kind of build up your networks and address any weaknesses that we identify during the running of our tool. So there's a couple different ways that you can address these in your response to the objections. You can either show us kind of your efforts to cure the deficiency, whether, maybe you've added some more providers to your network. You can submit an updated network adequacy template. We can rerun it. Maybe there's ongoing contracting efforts and you can, provide us some evidence of what you're doing to bring more providers into your network, or you can provide any other kind of clarifying information. For example, maybe you have some new providers on your list that weren't captured in last year's claims data, and therefore they wouldn't, kind of count in the tool going forward because they didn't bill last year. So if you provide that clarifying information, that's something we can look into to, make sure that those providers will count going forward. The other option is an exception request. So 270108 outlines any of the different ways that we can grant an exception to the rules. Specific examples for every line on your results, any line that's highlighted in red in the example that Morgan showed you, all of those should be addressed separately. So we don't want one explanation or one exception request for every deficiency on your list. They really should all be addressed separately and, specifically to the issue at hand. This slide just kind of outlines the general reasons that exceptions will be granted, and you should definitely review the actual rule 270108 for more details on those. But generally, the reasons that will grant an exception is if you can demonstrate that there's an insufficient number of providers in the area that you're looking at, or if there's providers that are refusing to accept contracting terms or rates for whatever reason. If that service is available in network for your plan with telemedicine or telehealth. If you'll pay for the required service at in-network cost sharing for an out-of-network provider because there's no other in-network providers available in the area. There's a commissioner waiver process that's outlined here. And then also, if the service in question is not a covered service for your plan, you could use that exception reason. Another question that we get pretty often is just, is there like a format that we expect you to submit back to us in response to the objection? We don't have a specific format for the response. Obviously, if you make any updates to your template, if you've added more providers, secure deficiencies, then you definitely want to submit us an updated template that we can run. Some carriers have found it useful to just submit their response right back to us in the results template. They just add another column, and that way it's ensuring that they're responding to each deficiency line by line, just as the results were provided to you. That's definitely not required. It's just something that we've seen work pretty well. So These are the contact information for our team. This is my contact information, as well as David Checkman and Karen McAllister. They're both examiners on the forms compliance team, and they'll be the ones reviewing your applications in SURF. So if you have any questions about the review, your results, the pending filings, you can contact us here, and we will get back to you to answer any of your questions. And I also want to open it up now to any questions that you have.
So one thing I did want to highlight too is that under our laws, the requirement is that, sorry, I just had it and I lost it. It's that there are sufficient healthcare personnel and sufficient numbers and types to ensure that all covered healthcare services are accessible to covered persons without unreasonable delay. This network adequacy template in our tool is one of the ways that we test this. This is not the only mechanism we use, but this is a good front end check to make sure that if you say there are providers in your network available in these specific areas, we're just cross-checking that with our claims information to ensure that, yes, those people are actually providing services in that area. So there are other ways that we are monitoring and enforcing these network adequacy rules. This is just one of those pieces. And I do see some in here, some of the questions that the network, on the network template, how are the provider type and hospital ASC or OSC providers, includes ERAP provider in network fields, columns K and L used in the network adequacy review process. So hospitals are a little bit different. We're not necessarily running that through our claims because it's a lot easier to quantify. We only have a certain number of hospitals in our state, so and that's a little bit easier to do a check by hand. So we do put on, I believe, health costs, Morgan. Is that where we have the hospitals?
Yes.
So on our health costs website, we have a link that shows which hospitals are in network, but that one's a little bit easier to do because there's a relatively smaller number of it. I think with respect to some of the other items and services, if they're being provided by one of those hospitals or surgery centers, I believe they'd still be captured by the tool. Is that correct, Morgan?
Yes, that is correct. And that those variables that Lisa had put in that question, we don't use those in the actual tool. The tool doesn't take into account the provider type. That is just information that we collect that we use for other monitoring and to be able to look at as the hospitals as well. But the tool doesn't take those into account when doing the actual analysis, just so you know, Lisa.
And then we have another one. Are virtual only providers allowed to be reported, or only those who offer in person with or without telehealth services? Telehealth can be used to supplement your network. It is not, I don't believe at this point in time, an alternative. You can't just have telehealth. If you're not meeting the network adequacy if you're not meeting the network adequacy requirements for a specific service in a specific area, you are encouraged to use telehealth to supplement that, but it would not be, you could not meet those requirements by just using telehealth. So I'm not sure how would that work in the template, Morgan? Is there a telehealth perimeter?
That ties into Lisa's question about the provider type. We have carriers that submit to us the provider type of telemedicine so that we know how many telemedicine providers they have in their network, and that we're able to see, not using the tool, but more so by hand, kind of like with the hospitals, how many telehealth providers are in their network and might be meeting those time and distance standards for that.
Yeah, so I think in theory, if there was a failure and we got an objection, not a failure, a deficiency,
Mhm.
and we got an objection clarifying that, there aren't many providers available in this area. However, we do offer telehealth and we have a number of providers that do that. We would be able to probably go back and look at your filing and identify, oh yeah, for this type of service, these people are on their network, they are indicated as telehealth. So that would be some of the ways that we would double check that for the purposes of this review during form filing. But as Morgan said, we do use this information for some of our other enforcement initiatives, I guess. Okay, on the slide about center of population zip codes, you have a table for the zip codes. When should we use those zip codes? These are, when we're measuring time and distance, we're measuring it from these zip codes to where the provider's located. So a good example is in Grafton, you would not have to meet the time and distance standards for all of the covered people in Grafton. You only have to meet them with respect to these reference zip codes. And that's why, if you know the geography of Grafton, these are 3 very different areas in Grafton. And so the time and distance is going to incorporate most of those areas. It also corresponds to, where you have some of those population centers and where you're going to have hospitals and other medical resources. If you're familiar with Grafton, the middle of Grafton, there's a mountain range going through it and it's very rural. So it would be unlikely you would be able to meet some of those time and different distance standards from the middle of Grafton.
One thing I want to stress on that is, and this was another frequently asked question we got last year, is that we aren't looking at the member and their zip code and where they live specifically, which I believe is different than some other jurisdictions. We are using these reference zip codes as more of a population center where the majority of the people in that county live, but it's not taking every single person's member zip and seeing how far they individually had to travel to a doctor. It's more so of the reference zip codes, which we know have the highest population in the county. What is it looking like for the providers around those? Is the provider, maybe they're located in the reference zip code, that happens a bunch, or how far away are they from that? So that is a big difference, and I know it's something that was asked and talked about a lot last year, so I wanted to touch on that.
Okay. Not seeing any other questions coming in, but again, if after the fact you have any questions, please feel free to reach out to us and we're happy, to work with everyone to make sure we can approve all of these products.